Good morning or afternoon, everyone, and thank you for joining us for our session today. My name is Kristen Reed, and I am a research coordinator with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series. So today we will be discussing motivational interviewing for the prevention of alcohol misuse in young adults. Our presenter today is Dr. David Foxcroft, President of the European Society for Prevention Research and Professor of Community Psychology and Public Health in the Department of Psychology, Social Work, and Public Health at Oxford Brookes University. Welcome, and thank you for joining us today. We would also like to wish a very warm welcome to all of our health evidence users that have joined us for this webinar today as well. So just to let you know, throughout the session today, we will be posting polling questions through our WebEx platform, and your participation in our polling questions is voluntary and anonymous. So I'll just leave this slide up for a moment to give you a bit of a time to look it over and then move on shortly. Okay, so just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available on Health Evidence's YouTube and SlideShare accounts. This usually happens within the next week or so, and both of the links to those resources will be posted in the chat section for you to access. So today we are very excited to be talking about the recent review, Motivational Interviewing for the Prevention of Alcohol Misuse in Young Adults. The link to the Health Evidence Review page for the systematic review will be posted in the chat section. You can click on the link and follow along in the review using the article full text or PubMed link out, and we will also be posting the direct link to the full text article in the chat box as well. So just a few housekeeping items before we begin. Please use the chat section in WebEx to post your questions or comments. We ask that you send your questions or comments to all participants and not just to the host. Also, please feel free to post your questions throughout the session. Towards the end of the session, we will try to be saving some time for the presenter to respond to any questions or comments that you might have. So a few more items. For the best connection, we recommend you use a wired internet connection versus wireless. And should you have any connection issues, we have posted the 24/7 WebEx helpline on the slide as well as in the chat section. For your audio today, we recommend that you please listen through your speakers. If you are having trouble hearing, you can go to Communicate at the top bar in WebEx and then click Audio Broadcast, and that generally tends to resolve some of the more common issues. So we have our first polling question of the day, and this can be found on the right-hand side of the WebEx platform. And we really just want to get a sense of how many people are joining us in our webinar today. So are you watching the session yourself with 2 to 3 people in a group of about 4 or 5, 6 to 10, or over 10 people? So we'll just leave that polling question up for a bit, and we are seeing that most people are joining with themselves today, by themselves today, but there are definitely also several groups of 2 to 3, 4 to 5, and 6 to 10. So that's really great to see. So I will leave that open for a bit and move on. We would like to give a very special thanks to our health evidence team who have worked to bring this session to you today. There is a large team of us who work to keep health evidence current and maintained, as well as to coordinate our monthly webinar series. So those of you who may not be familiar, Health Evidence is a service and research organization involved in knowledge translation for public health professionals that was launched in 2005. Our main product is a comprehensive registry of reviews where we provide over 4,700 quality-rated systematic reviews evaluating the effectiveness of public health and health promotion interventions. The main goals of health evidence are to make evidence relevant to public health more accessible and make it easier for professionals to use evidence in decision-making. So the value add for using health evidence is that we save you time. We have done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we are no more than 1 to 2 months behind the publication date. So we've done the work for you by critically appraising all reviews through a transparent process whereby you can actually click on the full quality assessment for each review and see our rating for each of our 10 assessment criteria. The Health Evidence website also has various tools and supports for evidence-informed decision-making available online, and many users have let us know that our tools and repository are both easy and simple to use. So I'm just going to quickly touch on the model for evidence-informed decision-making, which we can hopefully keep in mind as our presenter today goes through their systematic review. So this model consists of 5 components, and you can see them up here in the diagram. Traditionally, public health practitioners and decision makers consider evidence about community health issues in local context, existing resources, and community and political climate in making decisions about programs and policies. However, it has become apparent that considering evidence about research can be challenging to integrate into public health practice. As such, the Health Evidence webinar series is designed to highlight research evidence relevant to public health decisions. So going on from this, on this next slide, we can see the stages of evidence-informed public health that illustrates the steps involved in evidence-informed practice. The wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence into the decision-making process. So as you can see, there are 7 steps outlined here, and today we will be focusing on how the presenter has worked through the first 4 of these steps in order to help public health decision makers with the remainder of the steps in this process. So we have our second polling question of the day, and really we were wondering how many participants here today have heard of or are familiar with PCOS? So we have a couple answers coming in, and just a reminder as well to please press submit after you select your response so it can be recorded. And I think most people have heard of PCOS before, but there are a fair few who have not. So for those of you who aren't familiar with PCOS, it is really a way for you to structure your research questions. So it involves defining who the population is that you're interested in, what the intervention program or services that you want to know about, the comparison group, if there is any, and then outlining the specific outcomes that you are looking for. Also, sometimes we have a particular setting in mind, which we can also state here. So, for example, a school or community setting. So the value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question and can then help you search for relevant information related to your PICO more easily and efficiently. So I will move on to our next polling question. And really, we would just like to know how often do you use systematic reviews to inform programs or services that you're involved in? So always, often, sometimes, never, or maybe you're not really familiar with what a systematic review is. So we have several responses coming in. Thank you for responding. We have a few that are saying always, and then the majority, I think, are in often or sometimes, and a couple have never. So I will move on to introducing our presenter for today. We are really excited to have Dr. David Foxcroft with us to present this systematic review. So without further ado, I will pass it along to David. And David, thank you very much for joining us today.
I'm very pleased to be here. Hello, everyone. I've just been looking at the photograph, trying to remember where that was taken. I think it was taken whilst I was on holiday in Croatia, which is a beautiful country. We were cycling through the islands in the Mediterranean, It's a wonderful place. I do recommend it. If you get a chance, you must visit Croatia. Let's get on with the talk, though. And this is the first slide. The title of the talk and of the review is Motivational Interviewing for the Prevention of Alcohol Misuse in Young Adults. I want to just acknowledge the contribution of my co-authors, Lindsay Coombes, Sarah Wood, Deborah Allen, Almeida Santimano, and Teresa Moreira. They all contributed to the production of this review, and without their contribution, we wouldn't have been able to finish this significant and substantial piece of work. It was a product that was quite a long time in the making. The focus of the review was on motivational interviewing for the prevention of alcohol misuse. Why were we interested in alcohol misuse? Well, I don't really need to run through this list. I'm sure that you all know that alcohol is implicated in significant mortality and morbidity for non-communicable diseases. It's one of the major risk behaviours for the four main non-communicable diseases which contribute most now to morbidity and mortality internationally, and alcohol misuse has been implicated in the number of deaths in adults between the ages of 15 and 59. In fact, it's the leading risk factor for premature mortality in that age group. It's a significant problem, and that really raises the question, what can we do about it? Well, we would hope to be able to try and prevent harms from alcohol misuse. And in order to understand what we mean by prevention, I think we need to have some sort of a conceptual framework for prevention. Robert Gordon, in 1983, writing in Public Health Reports, suggested that we need to move away from conventional notions of primary or secondary prevention. These categories were originally developed for infectious diseases where the biological agent or cause could be very easily identified, but with more complex diseases, with more complex etiologies, the notion of primary prevention, i.e. prevention before the biological onset, didn't really make sense. So Robert Gordon, who was the Assistant Director to the National Institutes for Health in the US, suggested that we should move away from primary and secondary prevention notions to ideas of universal or targeted prevention. Universal prevention are those interventions which are targeted at everybody regardless of their individual level of risk, and targeted prevention efforts are those which are either targeted at particular groups who have been identified at higher risk, and that's selective prevention, or at individuals who are individually identified as being at higher risk, and that is indicated prevention. Now, Gordon's categories were endorsed by the US Institutes for Medicine in a report in 1994, and most recently in a report from the same body in 2009. So this classification system for prevention is being supported by significant bodies internationally. However, it really just describes the form that prevention takes, and in order to understand how prevention might work, we also need to consider the different functions that prevention might serve. And in this sense, there are some other categories that we might consider. Firstly, environmental prevention, i.e. those efforts which try to restrict the opportunities for engaging in risky behavior, for example, through some sort of environmental manipulation or intervention, for example, legislation or removing something from the local environment through policing or enforcement. And then we have also individual approaches to prevention. And the first of those is to try and develop an improved set of skills in individuals. And that can either be through socialization processes involving families or schools, or it can be more directly through training to develop better thinking skills, better behavioral skills, better coping skills in young people particularly, but also in adults. And then finally we have knowledge as a category, and that encompasses those interventions which just try and increase knowledge and awareness by communicating facts about particular risk behaviors, for example. And that might be, what are the risks, what are the dangers, how might engaging in a particular behavior make you feel, etc. And those interventions really are just about communicating information, so they're distinct from changing skills. So those three categories, environmental, skills, knowledge, which are more individual, really are the functions that prevention serves. And they go alongside, I think they sit alongside the different forms that Robert Gordon suggested quite nicely. In terms of the intervention that we're focusing on today, I think that it sits pretty well within the skills category in terms of what it's trying to do. The intervention is called motivational interviewing. It was originally proposed by Miller in 1995, who defined motivational interviewing as a directive, client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. It pertains both to a style of relating to others and a set of techniques to facilitate that process. And there are 5 main components to motivational interviewing. Firstly, adopting an empathic, non-judgmental stance, listening reflectively, developing discrepancy, rolling with resistance and avoiding argument, and supporting efficacy to change. So that's the particular counselling style that is used and counselling approach that is used. And the idea is to improve thinking and motivational skills in the people that are receiving the motivational interviewing intervention. It's also been enhanced or adapted, and the most widely used adaptation is an approach called motivational enhancement therapy, MET, and that combines motivational interviewing components with information around an individual's particular behavior. So it might give an individual feedback about their drinking behavior in the context of alcohol misuse. And we've included both motivational interviewing in its standard form and variations such as motivational enhancement therapy, as long as they also cover the 5 main tenets or components of motivational interviewing in our systematic review. So the question that we posed is, what is the effectiveness of motivational interviewing for the prevention of alcohol misuse in young adults? As with all systematic reviews, we undertook a thorough literature search. We searched a number of different databases. We hand-searched some journals. We trawled through papers to identify references that had been cited that may not have popped up in our standard literature searches. And through that process, we identified just under 1,800 records. We removed those that were duplicates, i.e. that appeared in the same record appeared in different databases, and that left 1,300, just over 1,300 records for us to look through. We screened all of those, and 1,210 were excluded because they didn't meet our inclusion criteria, and that left 104 full papers that we obtained and we read and assessed for eligibility. Of those 104, 77 studies reporting 84 trials were deemed to be eligible for inclusion in the systematic review. Now that's 77 papers and 84 trials because some of these studies, some of the papers reported more than one type of intervention, more complex designs. So we were able to separate those out and include overall 84 trials in the systematic review. With that number of trials, we were also able to proceed to a quantitative synthesis of the results of the different trials in a meta-analysis. But we weren't able to get information from absolutely every trial that we'd found in the right format for inclusion in the meta-analysis, even though we wrote to all of the authors of the studies where we were lacking the right sort of information. And that meant that of the 77 studies in the 84 trials, we were only able to include 68 comparisons in the meta-analysis. However, we also undertook sensitivity analysis to check whether those studies that weren't included would have been likely to have changed the results, and I'm pleased to report that it's very unlikely that that would have been the case. After we had screened and checked the papers for inclusion, we then went through each of the included studies to check for the quality, the methodological quality of the included study. And we used the Cochrane risk of bias approach to do that. And that gave us an idea of the likely risks for bias in terms of the studies that were included. This chart shows a low risk of bias in green, unclear risk of bias in yellow, and high risk of bias in red. And on the whole, there was generally a low risk of bias or an unclear risk of bias. Unclear means that the information wasn't available to us to make a clear decision. But there are some categories where there is a high risk of bias, particularly performance bias, and that's because it's very difficult to blind participants who are receiving the intervention from the fact that they're receiving an active intervention. It's very difficult to do that in behavioral trials, unlike in pharmaceutical trials where you can offer an inert placebo pill. And we'll come back to this issue later on in terms of discussing potential limitations. The other thing that we did is assess the potential for publication bias. Publication bias is when there's a risk that some studies that have been undertaken are not published in the literature and not identified in the systematic review and therefore not included in our meta-analysis. And it's usually those studies which don't find any effect that are not published because it's more easy to publish significant results. These four graphs show the effects of publication bias at different time points. On the top row, we've got, on the top left, a funnel plot which shows publication bias for less than 4 months follow-up for one of the outcomes that we were interested in, quantity of alcohol consumed. That is that in this group of trials, people were followed up after receiving the intervention at less than 4 months, and they were asked about how much they were drinking. On the right-hand side of the top row, you will see the same analysis, but for those trials which followed people up for longer than 4 months. So the outcome measure is the same, quantity of alcohol consumed. on the left-hand side, you can see that there is clearly more of an oval type of shape rather than the circular shape that you see on the right-hand side. And that's a clear indication of publication bias. On the bottom axis, you've got standardized effect size, and to the left of the dotted line, that indicates a favorable outcome for motivational interviewing. On the left-hand axis, you've got standard error, or the variability of the effect size, and a higher variability is associated with a smaller study. So this shows that smaller studies were more likely to be published if they had a positive significant effect. Interestingly, when we looked at the same funnel plot at more than 4 months, i.e. the graph on the top right, then you've got much more of an even distribution, and it does seem to be less problematic for publication bias. The bottom two plots show the same sort of thing, but for a different outcome. This one is binge drinking, and you can see there that publication bias is a potential concern for the shorter-term follow-up, but not so much of a concern for the longer-term follow-up. So that indicated to us that results from analyses over the longer term were potentially more robust in terms of publication bias. When we did the meta-analysis, this is the sort of chart that is produced. I know there's a lot on here, and I don't want you to try and read it all. I just want to point out a few things. The first is that this long list is all of the studies that were included in just one of our meta-analyses, and this is quantity of alcohol consumed at more than 4 months follow-up. The important line to focus on is at the bottom, where you've got a diamond shape and an overall effect size. This is the effect size where the pooled effect of all the different studies is shown. The diamond shape, you can see here, is to the left of a quite faint vertical line, and it's not touching that vertical line, and that indicates that overall there's an effect in favor of motivational interviewing, and because it's not touching the vertical line, that means that it's statistically significant. And when we look at the numbers over on the far right at the bottom, the overall effect is minus 0.11 with a confidence interval, a 95% confidence interval from minus 0.15 to minus 0.06. So that shows that this overall effect is statistically significant. The size is quite small because it's minus 0.1, and conventionally that's just a small effect, but it is statistically significant. I want to highlight here that statistical significance is not the same thing as substantive importance in terms of clinical relevance or public health relevance. And this is an issue that we will come back to. In fact, we'll turn to it right now, because the overall effect, the standardized mean difference from the meta-analysis of minus 0.11 can be expressed in perhaps a more meaningful way, and this is shown here in the text, which is highlighted in red. This is from the Cochrane Review Summary of Findings table, and what we were able to do is indicate that the meta-analysis of the finding of minus 0.11 corresponds to a decrease of 1.2 drinks consumed each week, and the accuracy around that in terms of the 95% confidence interval was from 0.7 to 1.6 drinks consumed each week, and that was from an average of 13.7 drinks per week, which is the usual level of consumption in young adults, down to 12.5 drinks per week. So that is the net gain from the motivational interviewing intervention in terms of quantity of alcohol consumed. If we look at another outcome, this outcome is frequency of alcohol consumption. I'm not going to walk you through the meta-analysis chart again. I'm going to go straight to the summary of findings account, and you can see here for frequency of alcohol consumption, which was the second of our 4 primary outcomes in this meta-analysis, that we found a meta-analysis effect of minus 0.14. That corresponded to a decrease of 0.22 drinking days per week. And there was an accuracy range around that, a 95% confidence interval that you can see. But the decrease of 0.22 drinking days per week suggested that there was a reduction from an average of 2.74 drinking days per week to 2.52 drinking days per week. So you can see that that is a pretty small effect, even though, again, this is statistically significant because the confidence interval around the overall effect does not include 0. The diamond does not touch that vertical line of no difference. So it's statistically significant, but there are questions about whether this is actually a useful or meaningful difference. Let's look at the third of our primary outcomes. This is binge drinking. That's the overall meta-analysis. I'm going to superimpose on top of that the summary of findings table, and highlighted in red is the textual description. The SMD from the meta-analysis of minus 0.04, so that's much smaller. If you look across at the meta-analysis chart, you will see the overall effect includes 0, and therefore it's not statistically significant. It's a much smaller effect. But what does that mean in terms of an interpretation? The effect of minus 0.04 corresponds to a decrease in binge drinking frequency in the previous month, this is month on this occasion, of minus 0.2 binge drinking occasions, from an average of 5.1 occasions per week to 4.9 occasions per week. And finally, this is alcohol problems. This is the fourth of our 4 primary outcomes, and you can see here that the overall effect size was minus 0.08, and this corresponded to a decrease on an alcohol problem scale. We use the Rutgers Alcohol Problems Index as our default scale, from an average of 8.91 to 8.18 in terms of the scale score. And this is a scale which ranges, I think, from 0 up to around about 60, so we've got a very small change there, and it's borderline significant. But I don't really want to draw your attention too much to the statistical significance. I'd really rather you focused on the issue of whether these are meaningful differences. Overall, this table shows the same results for the 4 outcome measures that we considered as our primary outcomes, 1, 2, 3, and 4. That's quantity of alcohol consumed, frequency of alcohol consumption, binge drinking, and alcohol problems. And you can see the text on the right-hand side is the illustrative change taken from the Cochrane Summary of Findings table, and we've already looked at the text for the first 4 of the outcomes, the primary outcomes from this review. We also looked at a number of secondary outcomes. We looked at blood alcohol concentration, both average and peak. We looked at drink driving, and we looked at risky behaviour. And the sort of pattern of effects that we found there was consistent with the pattern of effects that we found for the primary outcomes, that overall the effects were small. Sometimes they were statistically significant, sometimes not, but they were small, and the overall size is of questionable relevance in terms of public health impact. We also looked at the question of whether the duration of the intervention was important, whether the amount of time that was spent delivering the motivational interviewing was linked to the outcome, was linked to the effect size. And to do this, we did an analysis called meta-regression, which basically correlated the duration of the intervention with the effect size for each of the outcome measures. The point estimates given in this table for each of the outcomes indicate the size of that relationship. It's an indication of the slope of the regression. None of these was of any sort of substantive size, and you can perhaps see it most clearly in this chart, which is for quantity of consumption, quantity of drinking, which shows the range of MI duration along the bottom axis. Most of the studies were around 30 minutes, 20 minutes to an hour. We had one that overall was 235 minutes. And the effect size, which is called Hedges G, is a statistical measure of effect sizes on the left-hand axis. And you can see there that there is no clear visual association, visual relationship that we can detect between duration and effect size. And that's what the statistics showed us as well. So that we found no relationship between duration of MI, whether it was brief or longer, and the overall effects that were identified in terms of outcomes. So, where does that leave us? A number of summaries, a number of conclusions. The first thing is that this was quite a big review. We were successful in finding a substantial number of trials. Almost 23,000 participants in those trials were randomized to either the intervention, that is motivational interviewing, or to a control or comparison condition. We were particularly interested in studies with longer-term follow-up, 4 months or more, when considering sustainability of intervention effects. Did intervention effects persevere over the medium term and longer term? And as we saw earlier on, these longer term follow-ups are also less susceptible to publication bias. Overall, at 4 months follow-up, we found small effects in favour of motivational interviewing for the quantity of alcohol consumed and frequency of alcohol consumption. We found no or only marginal effects for drinking problems and binge drinking. Those were our 4 primary outcome measures that we pre-specified in this review. The quality of the evidence for primary outcomes was moderate, although there were concerns about performance bias, that is, lack of blinding, as we looked at earlier. Overall, our interpretation of these results is that although we found some effects, the effect sizes are small. They're unlikely to be meaningful in terms of public health practice. For example, we estimate that the quantity of drinking at 4 months, the SMD from the meta-analysis corresponded to an average decrease in the number of drinks consumed each week from around 13.7 to 12.5 drinks per week. We're not sure that that is a meaningful enough difference to conclude that this is an important intervention to be using. The other outcomes were of similar concern, small effects, and probably only marginal changes in terms of alcohol consumption and alcohol misuse. And that's summarized in the second bullet point on this slide. In terms of potential biases, I mentioned blinding earlier. Let's come back to it now. When participants are not blinded to study condition, we know from other work that there tends to be an exaggeration of overall effects. In a systematic review by Hobartson in 2014, they reckoned that when non-blinded participants were included in a study, the overall outcome was exaggerated by a standardized mean difference effect size of around about 0.56. Now remember, in our review, the effect sizes that we were finding were only of the magnitude of around about 0.1, sometimes less, sometimes a little bit more, but not much not far away from the 0.1 size of magnitude, size of effect. And here we've got a review showing that if you don't blind participants, then the standardized effect size can vary, can increase by around about 0.56, which is 5 times the sort of effect size that we were finding. It's therefore a strongly plausible hypothesis that the impact of non-blinding of participants in motivational interviewing trials could fully account for any small effects in our review. And that's a worry, particularly in behavioral trials with self-reported outcomes where there are small effects. We also looked at whether there was any potential conflict of interest bias. In a review by Petrosino, they looked at the impact of non-independent researchers and found that in trials where program developers were also the researchers, the mean effect size was around about 0.47 compared with 0 when the evaluation team were external and independent. In most of the studies that we looked at in this review, the people that developed the intervention were also those that undertook the evaluation. So there is a potential risk there. Petrosino concluded that the studies in which evaluators were greatly influential in the design and implementation of treatment report consistently and substantially larger effect sizes than other types of evaluators. So we couldn't exclude the potential risk of this sort of conflict of interest bias somehow impacting the sort of results that we were finding, even though they were quite small. Finally, we didn't find any relationship between the duration of the intervention in minutes and effect size. We also looked at a number of different subgroups, whether the comparison was a no treatment control or some sort of alternative intervention, whether the intervention was delivered in university or college settings or other settings, or whether the intervention was targeted at higher risk or lower risk or universal type of populations. And we found no difference according to any of these subgroups analyses. It didn't change the results that we found. So overall, and this is the final point, the concluding remark, we suggest that these achieved effect sizes would fall short by some margin of a minimally important clinical difference if further research were to identify a minimally clinically important difference for alcohol misuse in young adults. We don't currently have any agreement or consensus around what an important difference would be to achieve in this sort of research, but we reckon that the sort of effect sizes that we've been finding would fall short by a minimally important clinical difference if one were to be described and agreed. So that's the end of the talk. Thank you very much for your attention. I hope you found it interesting, and I'm going to stick around for a while and hopefully be able to answer some of your questions.
Thank you so much, David. That was a great presentation. It was really interesting to hear about, for sure. So we really appreciate you doing this walkthrough with us today. We do have a few questions that have already come in, and just a reminder for participants to start to add questions and comments that you may have in the chat section of the platform. Based on your final point there, David, I think this one kind of really fits in there. So here's a comment that says, thank you for this excellent presentation, especially the explanation of statistical differences and behavioral outcomes. And the question is, does this difference explain the apparent debate in the research about the effectiveness of motivational interviewing?
Could you say that again? Sorry, I didn't quite pick up what the question was.
Yeah, no, absolutely. I think the question really gets at kind of this the small effect size and the difference between statistically significant differences and perhaps clinically significant differences on behavioral outcomes. Would that explain the apparent debate that exists right now in the research about the effectiveness of motivational interviewing compared to perhaps some of the other studies or systematic reviews that have been done on this topic?
Yes, I understand. I think it's a really great point, and I think it does hit the nail on the head. There has tended to be an over-reliance on statistical significance in terms of interpretation of results, and Cochrane reviews have really done some great work in the past few years in trying to unpick the difference between statistical significance and clinical relevance or public health relevance. So Cochrane reviews, I think, are a little bit ahead of some of the other systematic reviews that you see published in this regard. But I think it's a great question, and I really do agree that there is, it's really important to focus on the difference between statistical and substantive effects.
That's great to hear your thoughts on that, David. Thank you. So another question that we have that's come in is in terms of the results of the binge drinking outcomes that you were mentioning, is the effect size of the non-significant decrease from 5.1 episodes to 4.9 episodes measured in episodes per week, or was it measured in episodes per month?
I can't remember without going back to the slide, but I did notice when I was reading it out that it said both month and week, and I'd need to go back and check that, but perhaps that's something I could follow up with, because I don't think I could do that quickly now.
Yeah, oh, absolutely. Okay, so another question that we have coming in is evidence suggests that just increasing awareness regarding the negative effects of alcohol is not very effective, and if motivational interviewing shows just a moderate effect on alcohol consumption, what interventions would you perhaps suggest for communities in order to decrease alcohol consumption in these different communities, provinces, and countries? Would something, I guess, looking for recommendations on your thoughts on policy approaches or working on increasing to increase resiliency in youth?
I think that we have to be clear that there's not going to be a magic bullet. There's no one thing that is going to have on its own a substantive impact, and motivational interviewing clearly is not going to have on its own a substantive impact. I think what we do need to think about are the different functions of prevention that I alluded to, that I pointed out at the beginning of this talk. We need to consider what approaches can be used in terms of environmental prevention, in terms of more developmentally oriented skills type of prevention efforts, and also how to provide information. I suspect that whoever asked this question is right, that just providing information, raising awareness is not going to achieve a huge amount. I think that the evidence for skills is more promising, but that it's more difficult to implement more complex skills-based initiatives in different settings. The evidence shows that these interventions don't always translate to different settings terribly well. We don't really understand why. That's an area of ongoing research. There is a growing evidence base for the effectiveness of environmental interventions, and I really do think that that should be an important focus for public health policy and practice in the future, but not to the exclusion of the others. We need to make sure that we get the balance right across all three. I do think environment needs to be covered comprehensively as well.
Thank you, David. That was that's really great to hear your thoughts on that. So I have a few more questions that are coming in, and I think this one really just gets right to the point. But we have a participant asking, so in a nutshell, are you saying that motivational interviewing is not effective for young adults regarding alcohol misuse?
I would say that on its own, yes. I would say that the evidence from the Cochrane review shows that there is really no confidence or very limited confidence in the potential of motivational interviewing. But as I said in the response to the previous question, it may be that using an approach such as motivational interviewing alongside other interventions, particularly environmental type of approaches, in a more comprehensive systems-oriented approach to prevention policy and practice for alcohol misuse would be appropriate. But on its own, I don't think that motivational interviewing is offering a lot for this particular population group. These are young adults in primarily college settings.
That's great. Thank you, David. And I actually think that kind of wraps in with our other question here, which is asking about other insights into other prevention interventions that could work in conjunction with motivational interviewing. So thank you for that. I think we do have another question here that is just asking if these trials were mixed between community settings and campuses. So, perhaps what are some of the types of settings that were included in the intervention?
They were mostly college settings, but we also had, when I say college, I'm using that in the sense of higher education in North America, Canada, and the US, because you use the word college to mean universities in the UK context. Over here, we also use the word college for further education. That's more applied type of career development for young people, where they receive training in skilled trades. So the sort of the sort of college training environment where we would train young people in particular trades such as electricians and plumbing and so on. So we call those colleges of further education, and there were a few of those included in the trial. We also had some healthcare settings, accident emergencies settings, or emergency rooms, as you guys call them, and a few other settings, but primarily college settings. But as I said, when we looked at the difference between these settings in terms of the results that were found, we found that there was no change or no variation in the results according to the different settings. So it's applicable, as far as we can tell, across different settings as well.
Thank you. That's really great. Thank you so much for sharing that. So I think a couple more questions that have just come in as well. So generally, did you find that motivational interviewing was incorporated with other interventions, meaning that it can be part of an overall benefit that includes other interventions, or were you looking explicitly at just motivational interviewing in this context?
We were just looking at motivational interviewing for the review. It was often included alongside other things, but we just focused on the motivational interviewing component. I suppose the broader conclusion to draw from that is that these sorts of combined packages, which include motivational interviewing, they may include things like normative feedback as well, are probably not going to be effective in the same way that our systematic review showed that just focusing on one of these things on its own is not effective. So I'm not confident that whether it's alone, whether it's delivered on its own, or whether it's delivered as part of 2 or 3 other things, it's going to change the results that we found. It won't change the picture, I don't think.
Very interesting, thank you. And I think this might speak to a couple of our other questions that are coming in. If motivational interviewing on its own is perhaps not as effective or found to be from this review, what kind of evidence are you aware of any kind of evidence around the impact of other interventions, so such as environment for the delivery of motivational interviewing interventions, or other type of skills initiatives in school settings?
In terms of school settings, there is some evidence for social skills. There is mixed evidence for family-based interventions. The real challenge, as I said earlier, with these sorts of developmental or skills-oriented interventions is that they tend not to translate well to other settings. That's an emerging finding that's coming through with a number of large trials that we've run in Europe based on skills-based interventions, family-based interventions that have been developed and tested in good studies in the US. We've also looked at more sophisticated information types of interventions. We did a systematic review with Cochrane on the effectiveness of normative feedback, and the conclusions were very similar to the conclusions and the results that I've talked about today in terms of motivational interviewing. There doesn't seem to be much gained from delivering normative feedback on its own, and so therefore in terms of information and skills we've got quite a mixed picture. Not so much evidence, good evidence for information, mixed evidence for skills-based initiatives. In terms of environment, then the evidence base is pretty sparse. It's quite difficult to do large randomized controlled trials of these big environmental interventions, but there are some papers which have looked at legislation, for example, drinking age, and showed quite clearly that there is a very positive impact of having a later age of drinking. So in the US you have 21. I don't know what it is in Canada, but in the UK it's 18. And the evidence clearly points to benefits to be had by delaying the legal age for drinking. There are also some studies which report positive impacts of enforcement. There's quite a nice study from Iceland which looks at how they managed to reduce teenage alcohol consumption from quite a high prevalence to quite a low prevalence over a number of years, and they did a number of different actions. A lot of those actions were around environment and enforcement rather than trying to give information or change the skills of young people. It's primarily around environment. So I think that that's an area for more work, although the evidence base is quite sparse compared to the number of high-quality scientific studies that we find in, for example, motivational interviewing or social normative feedback type of research.
Thanks, David. That's really interesting. And I think actually I may have read about that example from Iceland in the news this morning. So very, very apropos, I think. So we do have some other questions, but we are approaching the end of our time. I would just like to perhaps, before we wrap up, ask a few more polling questions that we have for you today. We'd really just like to know whether or not this information presented today was useful for you in your public health practice. So whether or not you strongly agree, neutral, disagree, or strongly disagree. So please continue to answer that as we go along. At this point, I would in the presentation, I would like to share a few options for ways that you can interact with health evidence moving forward. So these include visiting our website, registering to receive our monthly evidence service alert and monthly newsletter, which can keep you up to date on new reviews that are coming out on topics and areas of interest to you, as well as upcoming events and public health news. Tell your colleague about health evidence and perhaps some of the things that you've learned here today. Follow us on Twitter at our handle @healthevidence. And we also encourage your organization to use health evidence to search for and apply quality-rated review-level evidence to inform your program planning and policy decisions. And please contact us if you do have any other questions or suggestions for webinar topics, or if you'd like to provide feedback. So I will do one final polling question today as well. We're really looking at, with this kind of information in mind, what are your next steps? So do you plan to access the full text systematic review, access the quality assessment of the review that's available on health evidence, consider using the evidence, or sharing or telling a colleague about the evidence that you've learned today? So we will leave that polling question open as we close out. And I apologize we weren't able to get to all of the questions today, but I am sure that we would be happy to continue to hear your thoughts. And if you'd like to get in touch, please let us know. I would like to give a big thank you to our presenter, David, as well as to our audience today for posting questions and making this a very engaging and stimulating discussion. One final reminder that the copy of the recording and the PowerPoint presentation will be posted online in the next week or so. So thank you, everyone, and thank you very much, David. Do you perhaps have any final words before we sign off?
I'd like to say thank you, everybody, for turning up on your internet connection and listening to my talk. I appreciate that, and I hope you enjoyed it. And if you want to get involved in doing some Cochrane reviews, we're always looking for help. Thank you very much.
Wonderful. Thank you, David. And thank you, everyone, for joining us today.